So now can we please proceed with our next symposium, which is powered by ETHICON, and we are welcoming here Dr. Adarsh Chaudhary.
Thank you very much. My talk is on some new insights in anastomotic leaks. And at the very outset, I must tell you that my talk basically is only about colorectal surgery. We all know that anastomotic leak, once it develops after a colorectal surgery, is a disappointing event for the surgeon. It is not only the leading cause of mortality, but is the leading cause of increased length of stay, cost, intra-abdominal sepsis. It impairs the quality life of the patient, may necessitate the formation of a stoma, and there is now also evidence that anastomotic leaks are associated with a high chance of recurrence of tumors, and yes, needless to say, once an anastomosis is leaked, chemotherapy gets delayed. There are many factors which are believed to be associated with anastomotic leaks. Some are patient factors, disease factors, technical factors, and surgeon factors. All of them have not been proven to be conclusively associated with increased chance of anastomotic leak, but yes, male patients, because the pelvis is narrow, obesity, malnutrition, and definitely the site of anastomosis, the closer it is to the anal verge, higher the chances of leak, and definitely patients who have fluid overload, the bowel gets congested, there's an increased chance of anastomotic leak. Many of us have believed that some things we do decrease the chance of anastomotic leak, but the type and technique of anastomosis, whether you use single layer, two layer, continuous or interrupted, sutured or stapled, does not really matter. Using anastomotic reinforcement of omentum, prophylactic drainage, open or laparoscopic resections, and even transanal drainage is not supposed to be altering the chances of anastomotic leak in a patient who undergoes colorectal surgery. We still do not know what an anastomotic leak is. Still there is a debate on definition. Do intraoperative tests help? Are leaks presenting leak really late or they happen early? How can we diagnose these anastomotic leaks early? Should we operate, drain, are all areas of concern. For many years we didn't know what an anastomotic leak is. Is it only a subtle leak seen on a scan? Is presence of an abscess a leak? Is only a frank intracutaneous fistula leak, or patients who have features of sepsis also should be included? This controversy was solved in 2010 when an anastomotic leak was defined as a communication between the intra and extraluminal components. So even a patient who had a pelvic abscess, even if no communication can be demonstrated, should be labeled as an anastomotic leak. And there's a grading of anastomotic leak which sadly we do not use but can be very effective in communicating the type of leak. So we should use this grading more often to understand what's the degree of the leak. The highest amount of, the greatest chances of leak occur in patients who undergo colorectal or coloanal anastomosis, and that's the picture all over the world in all published literature. These patients have the highest chance of anastomotic leak. Apart from the usual things that we talk about, I'm going to talk to you about some newer things which we have learned in last 5 or 7 years which contribute to anastomotic leak. Because like you and me, many times we realize that sometimes our best anastomosis technically we do still leak. Why is it that happens? And now we are willing to understand that there are various factors which we have ignored all these years contribute to these anastomotic leaks. More than 100 trillion types of bacteria, fungi, and other organisms are in our intestines. And now we are beginning to realize that the intestinal bacteria are one of the potential drivers of anastomotic leak. There is evidence today that intestinal bacteria are contributed to the development of a colorectal cancer. But now we also know that the bacteria are responsible for contributing to an anastomotic leak in experimental studies, when you induce an anastomotic injury in a rat model, the bacterial flora changes. If you have to do nothing, even an insult to the injury changes the flora of the bacteria, and these bacteria, especially E. coli and other bacteria, start secreting collagenase and other inhibitory factors which increase the chance of anastomotic leak. And there have been studies which have shown that patients who have anastomotic leak, their fecal flora is different from patients who do not develop leak. The bacteria in these patients have changed, have morphed into something else which proposes the chances of leak. We many times believe that when you anastomose to an irradiated part of the rectum, it is because of the ischemia that leak occurs. Now we are also realizing ischemia contributes, but also it is the altered microbiome in the rectal stump which contributes to the anastomotic leak. Many of us as surgeons do not realize what's the value of the serosa, submucosa and mucosa in an intestinal anastomosis. The serosa merely seals the intestine from the peritoneal cavity and provides a matrix for the fibroblasts. Submucosa, which is rich in lymphatics and blood vessels, is the source of fibroblasts. So that's why it's the most important layer. And we do not realize the mucosa, which we believe does not contribute to the morphological integrity of the intestine, is the largest store of macrophages. We are realizing today that macrophage is one of the most important cells in the human body. It is the cell responsible for our innate immunity. And to keep things simple, macrophages are responsible for wound healing. Macrophages come in two types, M1 and M2, which is called the M1, M2 story. I won't complicate things for you, but whenever you have ischemia or infection, the M1 macrophages change, and when they change, they impair collagen synthesis and cause prolonged inflammatory response, which causes anastomotic leak. So in times to come, patients, and this happens many times in patients who have diabetes, patients who have are on immunosuppressive drugs, the macrophages get altered. So in times to come, if we can culture these macrophages, find out what is the flaw in them, we can probably predict the development of an anastomotic leak. You'll be amused to know that there is evidence appearing now that NSAID use in the post-operative period is associated with an increased chance of anastomotic leak. A meta-analysis of 24 studies showed that patients who received NSAIDs in the post-operative period, the NSAIDs affect collagen synthesis by altering the prostaglandins, they decrease tensile strength, so there is some suggestion that NSAID use in the post-operative period might contribute to increased chances of leak. Another interesting observation, which has been more often seen in patients who have esophageal surgery, if on an X-ray you see the aorta is calcified, this patient possibly has a greater chance of anastomotic leak. It is more suggestive in esophageal leaks, but some evidence is also coming in colorectal surgery. So we are beginning to realize that there are many factors which we did not know. We thought it's only our technical skill which matters, but many patient-related factors contribute to anastomotic leak. A question often asked is, does mechanical bowel preparation affect anastomotic leak? There is some soft evidence that mechanical bowel preparation with oral antibiotics can possibly decrease the chance of colonic leaks, but rectal anastomosis leaks are unaffected by mechanical bowel preparation. Does it make sense to do any intraoperative tests? Many of us do various tests, like we used to do a leak test and various tests, but now we are beginning to realize most of these tests are useless. The only thing possibly which can help us is the use of ICG, and there is more and more evidence coming that intraoperative use of ICG decreases the chance of anastomotic leaks and increases the chances of stoma formation in patients in whom the bowel is compromised. Let me give you one interesting nugget of advice which has come from literature. Suppose you do an anastomosis and you do an ICG study, and that anastomosis shows it's compromised If you redo the anastomosis, and whenever you redo an anastomosis, now it's advised you should always use a protective stoma, because these patients have a high chance of anastomotic leak. Another interesting study which came from the Dutch study, very interesting observation that you have two kinds of patients. One, patients who develop an anastomosis and leak becomes evident in day 1, 2, 3, or 4. And another group of patients in whom leak develops later. Is there a difference in these two patients? Evidence suggests that early leaks are technical and delayed leaks are more often related to patient-related factors. So your technical skill comes for early leaks. For late leaks, it is more often related to the patient's comorbidities and other diseases patient might carry. Since the anastomotic leak symptoms are so non-specific, many times diagnosis is made late by the time the patient becomes sensitive. So various markers have been used to diagnose an anastomotic leak before it becomes clinically manifest. The most commonly used parameter is a C-reactive protein, and if you put the knowledge together, what I learned was that a single value is not so important, but if you measure C-reactive protein on every post-operative day, and if every day the C-reactive protein rises by 50 or so, the graph goes up, the chances of developing an anastomotic leak which will need intervention is high. So a single value of C-reactive protein may not be of use, but a trajectory of the values of C-reactive protein may be useful. Another interesting observation is the fact that hyponatremia in the post-operative period is a surrogate marker of an anastomotic leak. To the extent in some studies, the specificity is 98%. Why is hyponatremia an indicator of anastomotic leak? It appeals to logic that whenever you have an anastomotic leak, the cytokines and other chemicals are released. They suppress they cause ADH secretion, there is water retention, and there is hyponatremia. So hyponatremia may be a surrogate marker of development of an anastomotic leak. So a conglomeration of factors put together might hint to you that a patient has developed anastomotic leak. The management of anastomotic leak, I'm not going to dwell much on it. We all know it develops on site of leak, the condition of the patient, what's the time gap from the primary operation, is it a free or a contained leak, and the degree of anastomotic dehiscence. My time does not permit me to go there, but the treatment options we all know are various, like antibiotics, a transanal drainage, a percutaneous drainage, and the patient who's very sick is to do a laparotomy. And if you see the databases, majority of patients will undergo surgery, and with the improvements in intervention radiology, many of these abscesses can be drained by percutaneous drainage. This is the most important slide which I want to emphasize, that how can we actually reduce the chance of an anastomotic leak? The answer is teach our juniors not to anastomose when an anastomosis is unsafe. You may be the world's best technician. If the condition of the abdomen is not good, if there is infection, if there is sepsis, no amount of sutures, no amount of staples is going to hold. So when you have a patient who's got hemodynamic instability, patient who has peritonitis, ischemic bowel, patients who have disseminated malignancy, immunosuppression, and when in doubt, conditions like this, when you have a patient who comes to you with trauma and has the triad of has hypothermia, has hypotension, there is acidosis, you do this anastomosis, no matter what you do, this is going to leak. The best answer for this patient is to divert and construct a stoma. So you have to match the trick to the terrain. So the safest anastomosis is one which is done in a patient who's fit and the abdomen which has no sepsis. And I've told you some newer insights like the use of the importance of a gut microbiome and the role of serum markers to diagnose anastomotic leak early in the post-operative period. Thank you very much. I'll be very happy to answer questions if you have any questions. Yes.
Hi, Dr. Adarsh, nice talk. What is your opinion on bevacizumab before and after intestinal surgery? Do you think it increases your risk of anastomotic breakdown?
Yes, I think there is evidence that all these drugs are associated with increased chance of anastomotic breakdown. Yes. You have any doubts?
No, I think especially pre-op, sometimes you have to be careful. For me, it switches
It's a
the
no-no.
handle to diversion.
We will
If
divert these
yeah,
patients.
yeah,
We will
yeah,
divert these
yeah.
patients. Yep.
What is your take on the prevalent practice, especially amongst robotic surgeons who deal with, sigmoid diverticulitis, with Hinchi 3, Hinchi 4, and they are very aggressive in doing resection, lavage, and then doing primary anastomosis. So what you are saying is more conservative, and what seems to be, to me, I'm not a colorectal surgeon, is a more aggressive approach, especially by the robotic surgeons. Do you have a take on this?
My first take is that properly the word you use, aggressive, is not justified. I think they are being too risky. Diverticulitis intestine is possibly one of the worst intestines, at least in our setup. Nearly 99% of them will construct a stoma because the bowel is so inflamed. Because today we only operate those patients of diverticulitis who've got complications and multiple complications. In the past, we used to operate patients who had 1 or 2 or 3 attacks of diverticulitis. Today, majority of patients who need surgery are those who have a colovesical fistula or some other fistula. So bowel is very unhealthy. I don't think it is very prudent to avoid a stoma in these patients. But each surgeon has to decide what he or she likes.
The issue of hyponatremia, does it hold good with Whipple's procedure also?
With what procedure?
Whipple's procedure, that there is an indication that there is a leak. And if you notice a patient is hyponatremic, it's very common actually in clinical practice, some disorientation. How do you proceed?
I have not studied hyponatremia as a factor in Whipple's, and I'm not aware of any publication. But based on the physiology, it's possible that it might also be happening there because it's a reflection of the SIADH. So, but I have not studied it.
Hello, sir. If there is gross peritonitis, the conventional teaching is not to anastomose. But I would like to quote the ladies' trial from the Netherlands. Perforated diverticular disease, fecal contamination, 2 arms, primary anastomosis or Hartmann's, there was no difference.
You're talking of a Hartmann's. Hartmann's is different.
No.
He's talking of a primary anastomosis.
In a fecal peritonitis for perforated diverticular disease, the Dutch ladies' trial, there was no difference. So, we can safely anastomose if the bowel is vascular in peritonitis, in that particular study. Ladies' trial.
You must be right, but I believe possibly it might be safer to agree. Maybe it may be a study on that. But a vast majority of us, we believe that a stoma might be a better option. If you ask me of the most difficult, challenging laparoscopic colorectal surgery is surgery for colonic diverticulitis. It's one of the most difficult surgery because bowel is inflamed, but I'm sure there must be some evidence on that. If there are no more questions, thank you very much for your time.